everyone. I'll be introducing Dr. Elfassy first. So Dr. Tali Elfassy joined the University of Miami Miller School of Medicine in 2018, serving initially as Research Assistant Professor of Epidemiology before becoming a Research Assistant Professor in Cardiometabolic Research within the Katz Family Division of Nephrology and Hypertension in 2020. She got her bachelor's degree in biology at NYU, followed by a master's in public health at GW before completing her PhD here in epidemiology at the University of Miami in 2016. Dr. Elfassy's work has been funded by multiple NIH grants and focuses on identifying drivers of hypertension disparities among U.S. Hispanics of diverse backgrounds, and in understanding the interplay between blood pressure and associations with cognitive functioning and dementia among, again, diverse U.S. Hispanic populations. She has published over 40 peer-reviewed articles, serves on a number of editorial and reviewer boards, and has received a number of distinctions, most recently in 2020 as an NIH/NIMHD Health Disparities Research Institute Scholar. We are honored to have her presenting today on the epidemiology of hypertension among U.S. Hispanics/Latinos. Thank you.
Thank you so much, Dr. Vincent, for that very kind introduction. And thank you, Dr. Weiss, and to the department for this invitation. It's really an honor to be here presenting to DOM faculty. So I'll be talking today about hypertension epidemiology among U.S. Hispanics. And this is, of course, very relevant to Miami with our very large Hispanic population. Oops. So I'll start with a little bit of background. So the first slide I always like to show is just the geographic region that encompasses Latin America is very large. Of course, when we talk about the Hispanic or Latin American population, we're talking about individuals that are from two continents, spanning a very large region, representing different cultures, different countries, different customs. So what about the US Hispanic population? How has it changed? How has it grown over time? So in 1970, there were approximately 9.6 million US Hispanics living in the United States, and this has increased to 62.1 million individuals, or about 19% of the US Hispanic population. Since 2010 alone, the Hispanic population has grown 23%. So this is the largest ethnic minority population and one of the fastest growing groups in the US. Where are these people from? When we talk about Hispanics in the US, even though this is a very heterogeneous group, most research is predominantly related to Mexican Americans, which are the largest Hispanic background group, encompassing about 62% of US Hispanics. However, we have about 38% of US Hispanics that are not from Mexico. And as you saw from the geographic region that Hispanics are from, this is a very different group from Mexican Americans, and yet most of our research is aggregated or extrapolated from what we find in Mexican Americans. So about 17% of the US Hispanic population is from the Caribbean. That includes Puerto Rico, Cuba, and the Dominican Republic as well. Another thing that I like to mention about the US Hispanic population is that it's changing. So in the 1970s, a large proportion of US Hispanics were foreign-born, and immigration was actually driving growth of the population. If we fast forward to 2010 to 2019, you see that the population growth among US Hispanics is really attributed to the US-born Hispanic population having children. So if you look at the percentage born outside of the US in 2007, it was about 40%, and in 2019, it declined to 33%. So the US Hispanic population is actually shifting in terms of the demographic attributes. Finally, the thing that I will highlight here is that there's also, aside from the sociocultural differences across all of these groups, there's also differences in terms of genetic admixture. So these are data taken from the Hispanic Community Health Study, which show admixture by Hispanic background group. And what you'll note here is that among Cubans, Dominicans, and Puerto Ricans, you have a lot more African admixture. And among Central Americans, Mexican Americans, South Americans, you have more admixture from the Americas. So there's genetic diversity as well in this population. I like to highlight this article. It's dated, it's from 2014. But if you're interested in reading more about the differences in SES, in genetic admixture, in sociocultural factors across the different Hispanic background groups and its impact on cardiovascular disease, I would really refer you to this review article, which is great. So with that said, I'll go into some of the data showing the epidemiology of hypertension. But before I do so, I really want to highlight the Hispanic Community Health Study. So as I noted before, the majority of the information that we know about Hispanics and the epidemiology of hypertension has been based on Mexican Americans. Because of the diversity of the US Hispanic population, there was a large coordinated push to obtain data in diverse Hispanics, so Hispanics from other background groups. And that was sort of the impetus for the Hispanic Community Health Study. So this is a large cardiovascular disease cohort study of about 16,000 US Hispanics from diverse backgrounds, designed specifically to obtain estimates of CVD risk factors in groups of Hispanics, not just Mexican Americans. So it includes Mexican Americans, South Americans, Puerto Ricans, etc. And one of the great features of the SOUL study is that one of the study sites is in Miami. So, if anyone's interested in this data set, we have very easy access to the data. So what do we know about hypertension in the US? It's the number one, it's the leading risk factor, the leading contributor to CVD, which is the number one cause of death in the US. According to the ACC-AHA guidelines, about 46% of the US population has hypertension. And if you look at this figure, this shows the prevalence of hypertension by race ethnicity according to data from the National Health and Nutrition Examination Survey. So this shows that compared to 47.3% of non-Hispanic whites who have hypertension, the prevalence of hypertension in the US is substantially greater among non-Hispanic Blacks at 55%. It's lower among non-Hispanic Asians at 36.7%, and then NHANES is showing that it is lower among Hispanics at 34%. But here I really want to note that the Hispanic population in NHANES is predominantly Mexican American. So this prevalence number, 34%, is really reflective of the prevalence of hypertension among Mexican Americans. So what do we know about hypertension in Hispanics, in US Hispanics? So again, from NHANES, we see the prevalence of hypertension is lower among Mexican Americans. These data are corroborated by the San Antonio Heart Study, which showed that the incidence of hypertension, and when we say incidence, we mean new onset cases, is lower among Mexican Americans compared to whites. But then if you look at other national surveys, which include diverse groups of Hispanics, such as NHIS or the National Health Interview Survey, we see that there is some heterogeneity in the prevalence of hypertension. So NHIS showed us that there is a higher prevalence of hypertension among Hispanics who self-identify as Black compared to white. Likewise, data from the MESA study, the multi-ethnic study of atherosclerosis, showed that there was a higher prevalence of hypertension among Dominicans compared to Mexican or Puerto Ricans. And again, longitudinal data from this study also showed a higher incidence of hypertension among Hispanics versus whites. So what do we see in SOUL, the Hispanic Community Health Study that I introduced previously? So these are data showing changes in systolic blood pressure after a 6-year follow-up period from visit 1 in 2010 until visit 2 in 2015, 2016. So overall, you see an increase of systolic blood pressure about 2 millimeters mercury. But what this figure shows is that there's substantial heterogeneity in baseline systolic blood pressure and the amount of change in systolic blood pressure among the different Hispanic background groups. And again, corroborating what we saw with NHANES in conjunction with those other studies, you see that Mexican Americans actually have lower mean systolic blood pressures than the other groups. You see higher systolic blood pressures among Cubans and Puerto Ricans as well. So now I'm going to focus on actual hypertension, not just changes in systolic blood pressure. So in this figure, you'll see the 6-year cumulative incidence in hypertension using data from the SOUL study. In these data, we're defining hypertension according to the ACC-AHA guidelines, so greater than 130/80 millimeters mercury. And this is stratified by sex. So on the left, you see in the blue, you see the incidence of hypertension over 6 years across all the Hispanic background groups. And I have Mexican Americans as the reference group because they're the largest proportion of US Hispanics, and they're also most of the data is based on Mexican Americans. So what's interesting here is that in general, about 22% of all participants who were free from hypertension at baseline became hypertensive at visit 2 after 6 years, compared with Mexican Americans who actually have the lowest prevalence of, the lowest incidence of hypertension, 17.6%. Incidence was substantially greater among Cuban and Dominicans. If we look at women, we see similar trends where Mexican American women had the lowest incidence of hypertension at 16%. And this was substantially greater in Cubans, Dominicans, and Puerto Rican women, so women from the Caribbean. Let's take a deeper look at it. So what my research is focused on is what is really driving these differences in hypertension? How can we explain why there is this heterogeneity? So what I've done here is I have incident rate ratios with Mexican Americans as the referent group. So I'll start with the gray bar and interpret this accordingly. So, and I'll focus on the significant findings. So among men, Cuban American men have a 58% higher risk of hypertension compared with Mexican Americans. Likewise, Dominican men have a 61% increased risk of hypertension compared with Mexican Americans. Now, after we adjust for SES factors, clinical factors such as BMI, smoking, physical activity, you actually do not see an attenuation of the incident rate ratio. In fact, you see it go up a little bit, which means that these factors can't explain the differences we're seeing in hypertension. So these differences exist even after accounting for SES factors, clinical factors, lifestyle factors. Now, when we look at women, we see something very different occurring. So focused on the age-adjusted only results, we see that Cuban women have a 46% greater risk of hypertension compared with Mexican American women. Likewise, with Dominicans, we see 48% increased risk, and Puerto Rican women, 71% increased risk. But if we adjust for all of these factors, we see a substantial attenuation in the risk. And among Puerto Ricans, we see almost a complete, like there's no association at all. So let's take a closer look at what's going on with women to see if we can determine which factors are really explaining these differences. So these are similar to the results that I showed on the previous slide, but here we're just focused on women. And the light blue bar represents the age-adjusted only model. So this is comparable to the gray bar on the prior screen. So if we take a look at Cuban women, we see that once we adjust for Model 2 and Model 3 factors, so SES and clinical factors, we still have significant differences compared with Mexican American women. But then once we adjust for behavioral factors, smoking, physical activity, and diet, we see the association go away. So what this is telling us is that these behavioral factors are the areas that are explaining the differences in hypertension among Cuban women. Now, when we look at Dominican women, we're getting a very different story. As soon as we adjust for SES factors, our association's attenuated and no longer significant, and this doesn't change with adjustment for more factors. So among Dominican women, the differences are largely explained due to SES factors. Now, when we look at Puerto Rican women, this is what we typically expect with additional adjustments in models. Each additional adjustment is explaining some of the variation in hypertension incidence to the point where after we adjust for lifestyle factors, we no longer have substantial differences. And of course, this is no longer significant. Okay, so we talked a little bit about which reasons are explaining these factors. I do want to take a little bit of a closer dive into a number of issues and just interesting points that have come up in these analyses. So I'm going to focus the next couple of slides on sociocultural factors, including SES and acculturation. So some of the differences that we've seen in the rates of hypertension by sex, which I think are notable, have to do with differential association between men and women. So in this graph, I'm showing the incident rate of hypertension. These are age adjusted and they're in person years. So this is the number of people who become hypertensive per 1,000 years of follow-up. And what we would expect is for individuals of lower SES to have higher rates of hypertension. Now, among men, you see that men who have less than a high school education actually have lower rates of hypertension than men with more education. Now, this is opposed to what we see with women, where those with lower education have higher rates of hypertension than those without a high school degree. So I'm going to focus now on acculturation, which is another important aspect of the U.S. Hispanic community. So acculturation is the process by which a person raised in one culture comes into contact with another culture and really adapts. It's shown to be associated with hypertension, but what I want to emphasize is that because the Hispanic population is so diverse and they have different immigration experiences, for example, Puerto Ricans or U.S. citizens can come to the U.S. whenever they want, to the mainland U.S., I should say, as opposed to, a Cuban where the policies were very different. They changed recently as well, and compared to a Mexican American. So the immigration process would be very different depending on where you're from. So I want to stress that I don't think acculturation is a uniform process, and it likely differs depending on your background group. I'm going to skip this slide for time and focus on results from Seoul. So these results show changes in systolic blood pressure according to nativity or the years spent in the US. So the clear white bar represents individuals who are foreign born with less than 10 years in the US. The light blue is foreign born 10 plus years in the US, and the darker blue is those who are US born. And of course, the clear bar represents those who are the least acculturated, where US born is a proxy for the most acculturated. So what we see here is that adjusted changes in systolic blood pressure are substantially greater if you have more acculturation or you're US born compared to those who are foreign born with less than 10 years in the US, among Central Americans and among South Americans. But if you look at Puerto Ricans, you see the opposite is true, where changes in systolic blood pressure are actually lower among the individuals who are more acculturated. So again, a differential association depending on Hispanic background group. If we look at a different proxy measure of acculturation, this is the SASH language scale, we see a similar trend where among Central Americans, more acculturation is associated with greater change in systolic blood pressure. And I see a hand up, but I think we'll leave it towards the end. Okay, so now I'm going to talk briefly about behavioral factors, and I'm going to focus on diet and in particular sodium and potassium. And here I have a graph from the InterSalt study, and of course, Dr. Stamler recently passed away. He was a pioneer in this field. And we see that there is an association between urinary sodium excretion and systolic blood pressure. So of course, sodium intake is associated with higher blood pressure, potassium intake is associated with lower blood pressure. So what did we find in the Seoul? So what we found is that in the Seoul study, potassium intake is too high. Right here we have the recommendation, and you can see the distribution of sodium intake among women and men, and it's above where it should be. And there is heterogeneity in the sodium intake depending on your Hispanic background group in both women or men. So among women and men, Mexican Americans had relatively lower intakes of sodium compared with Central Americans. And if we look at potassium intake, we have a similar story, except potassium intake is inadequate, far below recommendations. But Mexican Americans had relatively higher intakes of potassium compared with Puerto Ricans. If we look at the data together, sodium to potassium ratio, Central Americans and Puerto Ricans had highest sodium to potassium ratios. And of course, high sodium to potassium ratio is not good. So how is this associated with blood pressure among US Hispanics? So these data are still, in terms of the hypertension results, are still ongoing, but I just want to share some preliminary data. And of course, we see what we would expect, where increased sodium intake, and this is every 500 millimeter, every 500 millimeter increment of sodium is associated with greater change in systolic blood pressure over 6 years. And you see much stronger associations if we stratify by blood pressure medication, yes or no. So among individuals who are on blood pressure medication, and these are of course individuals with hypertension, we see a much greater increase in systolic blood pressure with greater sodium intake. So just some conclusions. The US Hispanic population is heterogeneous, right? Different groups have different risk factors. The rates of hypertension are very different depending on your background group. In general, they're lower among Mexican Americans and South Americans, higher in Hispanics of Caribbean, Latino, Caribbean origin. And then the drivers of hypertension really differ according to sex. Among women, a lot of the differences can be explained by SES factors for Dominicans, lifestyle factors for Cuban women, or a combination of all for Puerto Rican. Among men, differences are not explained by these traditional CVD risk factors. And acculturation is not a uniform process. We also see that sodium and potassium intakes differ by background group, and they can contribute to these hypertension differences as well. And really, a lot of research is needed to really explain these differences among men. With that, I just want to say thank you and really open it up to any questions or comments.
Thank you, Tali. That was a very nice presentation and very exciting information showing the importance of social determinants of health. One of the things that one gets bogged down in looking, especially at the Caribbean population, is whether these individuals were self-defined as their ethnic background or whether or not it was based on their place of birth, because there's a lot of mixing of Dominican, Puerto Rican, Honduras, and so forth among them all. So what's the purest way to really look at that, and what have you done in that regard?
Sure, no, thank you. That's a really great question. So I will say that for individuals who reported being mixed, they're sort of put in this other category, which includes people who identify as Puerto Rican or Dominican, or some combination of Hispanic background group. And it's been challenging, I think, to analyze data for this group that self-identifies as being mixed. Part of the challenge is that this is kind of a smaller sample. So the estimates that we're getting in this group is that they're not that stable. And it's unclear how to interpret this group because they're so different. And it's, are you identifying culturally as more Puerto Rican than Honduran, or it's difficult. So I think a lot more needs to be done with that respect.
Thank you. Good. Dr. Contreras.
Yeah, Tali, excellent talk. What I want to know is that if you find also an increased variability in outcome, in cardiovascular event outcomes among the Hispanics, and if that correlate with the, is graded according to the increase in blood pressure in this population over time?
That is a phenomenal question. And so something that's, very interesting that I didn't necessarily touch on is the Hispanic paradox, or what's now being known as Hispanic resilience. And basically what's occurring in this population is that you have a large amount of the socioeconomic vulnerability, right? The Hispanic population is predominantly socioeconomically disadvantaged. And we have, high prevalence of cardiovascular disease risk factors, yet the incidence of hard cardiovascular disease outcomes and mortality among US Hispanics is actually low. And we've seen this in Seoul. So I have a number of proposals looking at risk factors and associations with hard CVG outcomes. And the sample sizes are just very low because there aren't enough events, which is, it's a great thing. But so we haven't, even the incidence CVG paper has not been published using Seoul data because one of the reasons, the number of events is actually very low. So this is to be determined, has not been released yet, to answer your question.
Thank you.
Okay, well, thank you very much, Dr. Elfassy. That was a great talk, and we really appreciate your presenting to us what you're doing. Thank you. From the Division of Nephrology. Great. Okay, Dr. Vincent, please introduce our next speaker.
All right, so our next speaker is going to be Dr. Goldberg. Dr. David Goldberg joined the University of Miami in 2019, serving as Associate Professor of Medicine within the Hepatology Division. He completed his undergraduate studies at Brown University before getting his medical degree from Mount Sinai School of Medicine. He completed his internal medicine residency at New York Presbyterian Hospital and both his gastroenterology and transplant hepatology fellowships at the University of Pennsylvania. He has co-authored over 150 peer-reviewed articles and serves as deputy editor of the Liver Transplantation Journal. He has piloted a number of highly funded projects investigating means to improve allocation of livers for transplantation, expand access to kidney and liver transplantations, and predict outcomes of these transplantations. Most recently, he is piloting the Thinker Next trial of transplanting hepatitis C viremic kidneys into hepatitis C negative recipients. He was recognized in 2020 with the American Society of Transplantation's Innovation Award. We are honored to have him presenting today specifically on transplanting health services research into healthcare policy to improve the system of organ transplantation. Thank you.
Thank you very much for the introduction. The talk today, some of this is sort of follow-up to when I first gave grand rounds about 2.5 years ago when I came here, but I want to talk about some of the research that I've been doing since coming to the Miller School, but also showing how, what we do in terms of research and publications can lead to more than just a journal article or a grant, but can really have an influence on the healthcare that we deliver to our patients. So I do have disclosures relevant, although it really has not affected the work. So the objectives here are to review research related to hepatitis C and organ transplantation, discuss the system of organ donation and ways to evaluate OPO performance, but to highlight how health services research can directly impact the practice of medicine. So the first part is to discuss how increasing the number of organ transplants by utilizing previously discarded organs. So some of this is a sort of refresher of what I presented about 2.5 years ago in terms of the utilization of kidneys from hepatitis C infected donors. And really, this should say really not just kidneys, but all organs. So prior to 2016, there was actually an incomplete understanding of how many hepatitis C infected donors there actually were in the US. National registry data only captured donor antibody status. So any study prior to 2016, where they talked about utilization of deceased donors with hepatitis C, really sort of had to be taken with a grain of salt because we actually didn't know how many of those donors had hepatitis C. And there were only a few hundred hepatitis C positive kidneys that were transplanted at the time. In terms of other organs, so livers, historically, we've used a lot of organs from donors with hepatitis C because there was a high burden of hepatitis C among patients waitlisted for a liver transplant. Prior to the last few years, hepatitis C was the most common indication for a liver transplant. Kidney, there was limited use in patients except those with genotype 1 hepatitis C, because there was a concern of genotype switching with the donor to recipient, and there were treatment difficulties in the sort of era of interferon in terms of treating hepatitis C. Lungs and hearts from donors with hepatitis C were rarely used because pre-transplant hepatitis C in recipients was thought to be a sort of contraindication, and there were concerns about post-transplant outcomes both from donor and recipient hepatitis C status. So Later on in the talk, I was sort of take away the white boxes here, sort of showing where things are now. But prior to 2016, you could see that kidneys and livers, there were some numbers of hepatitis C infected organs that were used. Hearts and lungs, you see no green, because if a donor had hepatitis C, it was in essence an automatic exclusion from using the heart or lung. Now, things changed around 2016, both in terms of treatment and availability of donor organs. So this is a schematic of the sort of rapidly advancing landscape of treating hepatitis C, and sort of drew a box around the sort of 2014 to 2016, when there were all oral regimens approved to treat hepatitis C with over 90% cure rates with limited side effects. At the same time that these drugs were approved, there was a change in the sort of profile of deceased organ donors. And you see there was a rapid increase in donors who died either from a drug overdose as the direct mechanism or another mechanism, but had active illicit drug use, which again was associated with having hepatitis C in donors. Given this landscape, when I was previously at Penn as a faculty member, we, along with the group at Hopkins, launched the first 2 clinical trials of transplanting hepatitis C infected organs, and the first trials were kidneys, into hepatitis C negative recipients. Both trials at the time, and again, this was designed in 2016, used grazoprevir or elbasvir, which is Zepatier, which was limited to genotype 1 and 4 hepatitis C. This medication is sort of infrequently, if ever, used because of the limitations, but this is what we had available back then. The Thinker trial at Penn, for which I was one of the co-PIs, required real-time donor genotyping. So we had to make sure the donor had type 1 or 4 hepatitis C per our protocol. We treated patients on day 3. All 10 were initially cured, and we then expanded it to 40 patients. 39 out of 40 were cured. Johns Hopkins had a study, the Expander trial, where they used all genotypes, but they used sofosbuvir if people had genotype 2 or 3. They started treatment on call to the OR, and they had 10 out of 10 that were cured. So these studies that were published in 2017 and 2018 were the first published clinical trials of knowingly infecting people with hepatitis C through organ transplantation. Over the next several years, there was a rapid increase in the number of publications of studies transplanting organs from donors with hepatitis C into hepatitis C negative patients as a result of the Thinker and Expander studies. In abdominal studies, there was a quote unquote real world experience of kidneys and livers from Cleveland Clinic, both in Weston and Cleveland, where they did 64 kidneys. 41 were cured SVR12, 10 were negative at the end of treatment, and 7 were still on treatment when they published it. They then did 4 livers and 2 liver kidneys. And again, everyone appeared to have response to treatment, although when they published this, some people were still undergoing treatment. Methodist University in Tennessee did a standard of care approach where they actually switched everyone on the list to be active for hepatitis C infected kidneys. Many of them didn't know that this was happening at the time. They did 53 kidney transplants, and they treated people starting at 1 to 3 months after transplant, and everyone was cured. Within the thoracic world, Vanderbilt was really the first to have large numbers of data, and they did a standard of care approach where everyone was eligible, but they had a special consent process. They published data on 70 recipients. They had excellent 1-year survival, and everyone that survived to the SVR12 or hepatitis C cure period was cured. Brigham and Women's, which was actually a formal trial, did 4-week, so short course or 4 weeks of Epclusa, and they started treatment within a few hours post-transplant. They did 36 lungs and 8 hearts, 44 in total, and everyone was cured. Toronto General did a protocol where they did ex vivo lung perfusion, and they actually pumped the lungs with a fluid that was actually exposed to UV perfusate. What they actually found is that 2 of the patients actually did not even develop hepatitis C. The other 9 were cured. There have been now, over the last several years, due to the success of early trials using standard of care treatment, novel treatment approaches that have been considered with varying success. So the group at Toronto has done short course of GP or Mavorit, which is the drug by AbbVie, where they then give patients ezetimibe or Zetia, which is a cholesterol medication, but also actually has activity in blocking hepatitis C entry into hepatocytes. And they start both of these 6 to 12 hours prior to transplant. The thought is that Zetia may serve to block hepatitis C entry into cells and actually decrease the probability of hepatitis C transmission. They published data on this a couple of years ago where they cured 30 patients across different organs with only 7 days of therapy. The group at VCU pioneered an ultra short duration with an adaptive approach. So they did several iterations. Everyone received 1 dose of hepatitis C treatment on call to the OR, and then they gave differing doses, a number of days of treatment post-transplant. When they did 1 to 2 days post-transplant, 45 out of 52 were cured, so 7 of them required full dose therapy. They then expanded it to 7 days post-transplant, and 48 out of 50 were cured. Again, 1 dose pre, 7 dose post. Of the 9 that were not immediately cured and required retreatment, 2 required full course, and 1 actually required 3 full courses. So what you see here is sort of differing approaches to doing shorter course of therapy. The benefits largely being cost, but this is sort of different approaches that have been tried. And then there was a study from the group at Hopkins where they did short course of GP or Mavorite for 4 weeks post-kidney transplant. They started the treatment on call to the OR, and 10 out of 10 were cured. So there have been a lot of now different experiences of using hepatitis C infected organs. Where do things stand now in the US, and what's the current landscape? So some centers now offer this as standard of care. They'll talk about older donors, donors with a sort of higher risk profile, and donors with hepatitis C. There is variable consent and regulatory oversight. So all centers have to provide informed consent about this. What level of informed consent they're providing is not standardized. Insurance approval of therapy is not guaranteed and may be delayed, and there have been reported cases where insurance delayed and or outright denied hepatitis C therapy because technically this is off-label because hepatitis C therapies, none of them are approved for acute hepatitis C. And there have been emerging publications of potential unanticipated risks. The Methodist group had increased risk of BK virus and CMV virus in these recipients. Both Methodist and Cleveland Clinic had fibrosing cholestatic hepatitis C cases, sort of the dreaded complication post-transplant of a severe acute hepatitis C. The VCU group had multiple treatment failures, including 1 person that required 3 different courses of therapy. Toronto group had another study where they had relapse rates that were 10%. Mayo Jacksonville had a case where they actually had insurance delay when they did a hep C positive to negative liver. The insurance delay, then the patient had a post-transplant hepatitis C related glomerulonephritis, developed end-stage renal disease on dialysis, was eventually cured, but then died a year after transplant from complications of renal failure. And there have been insurance denial. So again, this varies across the US, but at Ohio State, 35% of their patients who got a hepatitis C infected kidney had initial denial by insurance company, and 10% of their livers. And again, we had published this a couple of years ago. There's been a disturbing early pattern in disparities of utilization of these kidneys, where there's been decreased use in racial and ethnic minorities, women, and those with less education. Now, the good side, and sort of taking away that white block that I showed before, is how the work I think that we started in 2016 and other centers have done has changed the utilization of these organs. So again, we have in green here the number of kidneys and organs transplanted, and we were at 200 to 400 when this first started, to now over 1,000 hepatitis C infected kidneys being transplanted every year. Livers, again, sort of up a little bit. But hearts and lungs, also, those are still a lot more orange than green. There's in total been close to 1,000 hepatitis C infected heart transplants done since the first studies that we did in kidney, which never had been done before. Lungs are lagging, but still, again, about 600 to 700 lung transplants that have been performed that never would have been performed until this sort of advancement in care. Interestingly, there's also been a flip in sort of who is getting these organs. So early on in kidney transplantation, hepatitis C infected organs were used in hepatitis C negative recipients. But with the change in sort of being able to cure hepatitis C pre-transplant and the safety of these studies, we've seen that almost all of the hepatitis C infected kidneys are going into hepatitis C negative patients, which is sort of pretty staggering. And last year, more than 90% of the hepatitis C infected kidneys were used in people without hepatitis C, For those who were practicing, 10, 15, 20 years ago, this is sort of unheard of, where hepatitis C was a dreaded disease, and now we knowingly infect people routinely. Similar patterns seen in heart transplantation, lung, and less so in liver. Now, there still are clinical unknowns about this, which is why we launched the Thinker Next trial, an NIH, NIDDK sponsored clinical trial. So again, this is an 8-center NIDDK funded U01 of 8 sites, although we've now switched one of the sites out due to lagging enrollment. I'm one of the 3 overall study PIs, along with 2 colleagues at the University of Pennsylvania. And we're still trying to address some key unanswered questions in hepatitis C donor positive, recipient negative kidney transplants. So what are the hepatitis C cure rates with narrow confidence intervals? Again, there's published data of 20 patients, 30 patients, 40 patients with excellent cure rates, but we also know there are experiences of lower cure rates that centers have chosen not to publish their data. So we really want to be able to provide an accurate estimate of what the cure rates are. What are the outcomes compared to well-matched hepatitis C negative comparators? So currently, donors with hepatitis C are considered quote unquote worse. They get worse scores of the kidney score, and we want to know how do the outcomes compare, both in terms of allograft function and the potential benefit of accepting one of these kidneys. We want to really look at the post-transplant risk of CMV, and we have a team of ID adjudicators, including Shelley Morris at Miami, really trying to see, are these patients have a higher risk of getting CMV? And what about what hepatitis C is doing on a microscopic level in the kidneys from donors with hepatitis C? So now switching gears to another area sort of research is increasing the number of organ transplants by increasing the number of recovered organs. So this topic is probably going to be a little foreign to people, so I just want to give us some basics. So the system of organ donation is very complex in the US, with donor hospitals, donation organizations, transplant centers, and federal government and regulators. The Organ Procurement Organization is responsible for managing organ procurement and recovery process. It's sort of like the general manager of a professional sports team. There are 58 and now arguably 57 of them, and they operate within a designated area, as I'll show in the next map. So there's organizations, and they're responsible for all aspects of deceased donation in a given geographic area. There are nonprofits, and they're compensated through contracts through CMS and transplant centers. And the primary source of oversight and certification is CMS. And this is a map here. So you see FLMP is our area. LAOR, the Life Alliance Organ Recovery Agency, which is actually in our Department of Surgery, is the OPO in our donor service area. You see they have varying sizes in terms of population and geographic landmass. Now, how are these organizations measured? So since 2006 until more recently, they were measured using 2 metrics: a donation rate of the donors per 100 eligible deaths, and the organ yield, the number of organs transplanted per donor. A donor was defined as someone with an organ procured with the intent to transplant. If no organs were transplanted, they were still considered a donor. And an eligible death was a self-reported thing by each OPO. The age sort of expanded, but it had to be someone that died in a hospital. They were brain dead per hospital and state policies, met criteria for medical suitability for which there was some subjectivity, but there were limitations. So it was, not limited to the conventional concept of a donor. An eligible death, like I said, was self-reported. They had to be brain dead, even though about 20% of donors in the US are not brain dead. If a family declined consent for a donor, they weren't counted. And unfortunately, it was a metric that could be manipulated. And this is sort of one of the big problems with it. So these are data from an OPO in the Northeast that was almost decertified by CMS in 2013. You see here, their donation rate or authorization rate was about 55%. Between 2013, when they were almost decertified, to 2014, their authorization rate went up from 55% to over 70%. Now, there's obviously 2 ways that they could have rapidly gotten better. They either rapidly got better or they changed how they reported the data. As you can see here, this OPO didn't get better because the number of donors was essentially the same. What they did is that the number of eligible deaths went from 350 to 300. They changed how they reported their denominator to make their overall performance better. As a result of this, they avoided being decertified, but obviously were unfortunately gaming the system. So how could this metric mask underperformance? So, sorry. So one of these two OPOs was the OPO that I was showing in that figure, but one was in New York and one was in Philadelphia. What you see here is the underlying population is fairly similar. The number of deaths in those two areas is similar, and the number of people dying in a hospital under a certain age from causes consistent with donation was almost identical. But what you see in Philadelphia, they had 576 reported eligible deaths, while New York had 420. Philadelphia had almost double the number of donors, yet by the metric from CMS, the donor authorization rate, the two of them were performing almost the same, which obviously that's not the case. So this has led us to doing work to identify what should be the optimal denominator of potential deceased donors for an OPO metric. And we drew this circle that, we've used in several different talks, but what is the denominator and how could we think about ways to measure OPO performance? In gold here is sort of the gold standard of reviewing the medical records of all inpatient deaths of every patient who dies in the hospital in the US, which is obviously infeasible. Red here was the self-reported data from eligible deaths, which was smaller than the actual denominator of eligible deaths. So clearly there was a problem with how it was being measured. So we proposed that the way that it should be measured, the performance, was something called the CALC metric, the cause, age, location, consistent with donation metric, looking at inpatient deaths under, and it was actually now adapted to less than or equal to 75 years of age from causes consistent with donation. We published this paper back in 2019 proposing that this should be the metric used by CMS. And actually, at the same time, there was a big push within the sort of, transplant system, but even more within the political system to actually reform the system of organ donation. And I highlight this is one of the few times where you could see both Todd Young and Elizabeth Warren on the same page of something. So there was bipartisan support for reforming organ donation. At the same time, we put out this paper proposing a new metric. CMS then in December 2019, about 4 months after we published this paper, put out a notice of proposed rulemaking to change how we measure OPO performance, where they would remove the eligible death metric and use a donation rate metric. And they proposed one of two metrics, our CALC metric or different metric where they looked at inpatient deaths who didn't have a contraindication to donation. And they wanted to look at both a donation rate and a transplant rate using our metric or a variant of the metric we had proposed. And they said that the bottom 75% at the end of each 4-year cycle would be decertified, which was very scary to the 58 OPOs, because that would be, almost 40 plus of them that could be out of business. So when CMS put out this rule in 2019, there was a lot of sort of, opinions on both sides. So it depends on who you are. The transplant centers were largely supportive because the hope is that a metric would not only make OPOs perform better, but also get rid of those that were habitually underperforming. The high-performing OPOs were largely supportive. The low-performing OPOs were largely opposed. So again, same topic. You could read some of the articles in the lay press here. Some were very positive, and some were very negative, with one saying that this new rule will bring chaos. There were concerns raised about the potential metric and sort of what we had proposed in our article and what CMS put out in terms of concerns about the death certificate, the exclusions, which I'll get into, risk adjustment, how many could be decertified, and time lag. So again, this was a health policy thing put out there, but there was asking for health services research to actually address some of these questions. So one of the concerns put out was that death certificate data wouldn't look at ventilation or comorbidity data. And as you can imagine, someone who wasn't ventilated couldn't be a donor. Someone with significant comorbidities, metastatic cancer, couldn't be a donor. So we actually looked at this and actually tried to address this question. So the question really that mattered was, does including ventilation and comorbidity data beyond what's available in death certificate data improve the metric? What we found, and again, I'm not going to get into the specifics, I'll show some of the figures, is that obviously if you whittle down the denominator with more granular data on ventilation and sepsis, you will decrease the denominator and the overall metric, the sort of donors per potential donors, goes up. But what we've published here is that, yes, it changes the metric. And you could look here on the x-axis is the actual metric that we had proposed. And the y-metric, the y-axis is if you had a metric looking at ventilation data. The scales are different because you decrease the denominator, you increase the overall number. But what matters from the perspective of CMS and what we put out in our papers, it doesn't matter when you're comparing groups. Again, if this was a baseball analogy, the batting average and the on-base percentage are different. The on-base percentage is a little bit higher, but it's measuring similar things and allows you to compare people in a similar fashion. Then there was a concern about the time lag. So CDC death certificate data have about a 12 to 18-month time lag. And some of the OPOs were saying, well, if you use data that's a year and a half old, what if we rapidly get better? So a paper we published shortly after I joined the faculty with several people, including Ellie Niraman, who's one of the third-year residents who will be a GI fellow here next year, looked at this very question. And we looked at data over an 8-year period and looked at these decertification cycles and said, okay, there's a time lag. Let's look back in time and say, how would it have mattered if you actually had data in real time as opposed to this time lag? And we looked at, are there rapid changes in the absolute value of a donation rate? The number of donors may go up year to year with the number of deaths, but do things actually matter in terms of the donation rate? And this was the first paper focusing on year-to-year changes in donation rates. So there's often sort of things out in the lay press, like we have a record number of donors this year. But of course, if there's more people dying from certain causes, that's why there's more donors. Not going to get into the specifics. You can see the colors are pretty static throughout. What we showed and what Ellie showed in this paper is the time lag doesn't really matter. This is just a sort of scare tactic to say why they shouldn't use this metric. But if you're good, you're good. If you're not good, you're not good. And rapid change doesn't happen often. And again, that's what this figure shows. The asterisks are those where there's rapid improvement from one year to the next. And you could see it almost never happens. And again, one thing we did show is that actually the one thing that does make a difference is having a leadership change, and those OPOs that had CEO changes maybe got better. So that was something to address. So all this put together sort of, was a very interesting process of how a notice of proposed rulemaking goes out for public comment. But then the Federal Register final rule that was published in 2020 and then finalized in 2021 actually put out a metric, a rule for OPOs that was using research that we had done with a donation rate and a transplant rate that was based on the calc metric, with a tiered approach to potential decertification because of the concerns about decertifying 75% of OPOs. But this rule is now in effect and has the potential in 2026, if not sooner, to lead to decertification of OPOs. And as a health services researcher, it's always cool to see your paper cited in a talk, but this was sort of the highlight for me to see my name in our research highlighted in the Federal Register back in December of 2020. So in conclusion, the organ transplant system is ever evolving. Clinical epidemiology and health services research has the potential to change policy and healthcare delivery. The research you do has impacts beyond just a publication. And with that, I'd like to acknowledge all of my collaborators and funding sources and government officials in both the current administration and the prior administration who really helped to transform research into healthcare policy and really improve the system of organ transplantation in our country. Thank you,
Dr. Goldberg, that was a tour de force. It goes to show you how specific attention to detail can truly be a change agent for government bodies such as the OPO. Today, we read in the newspaper, unfortunately, about the death of the heart transplanted patient. That notwithstanding, he has survived 2 months. What do you think is the future of xenotransplant, and how will that affect the way in which we look at organ transplants in the United States in the near future?
So, I think that's a very interesting question that, a lot of us have been talking about in the transplant field. I think, I guess I've been in this field for 10 years, and every year at meetings, they said, in 10 years, this will be the future. And we're still a ways away. I think the heart transplant was exciting, but I think also shows how far we have to go. Now, we obviously don't know what the person died from or things like that. while that one was successful, there were 2 studies in kidney transplantation. Well, one study, 2 press releases, where the outcomes arguably maybe were not as good. The group at UAB had published, and they were able to successfully transplant, but there were some concerning pathological findings of TMA, or sort of, endothelial injury. So I do think that that is still a ways away from my understanding of it. I think one of the big things is that we have to show sort of longer term outcomes to be able to make this a reality. I think there's a lot of regulatory, a lot of debating within the field. I think it's still some time away. I think in my career, I think we'll see it as a reality. But again, I think people have been talking about this as the future going forward. I think we're closer, but I think we're still a ways away.
Thank you. Dr. Comandori.
Hey, David, beautiful talk. I have a question about the fact that, these metrics that you're developing, and I think it's really thoughtful to, in the transplant, hematopoietic transplant setting, we have centers of excellence, and we have HRSA actually mandates, an index that's actually publicly visible for transplant outcomes. It's a slightly different thing, but obviously we're getting to the point where we can, we have to have non-gameable metrics of outcomes, right? And that's basically what you're working on. I'm wondering how you think about these kinds of metrics in the next phase of our health financing realm being used to actually determine how we compensate people. In this setting, it could be that you actually compensate people on the basis of how well, how efficiently they're using resources to procure organs, or obviously you could use similar metrics to actually pay people variably for performing a transplant or their one-year outcomes. And I'm curious, since your work is so relevant to, the kinds of metrics that could be used for those purposes, how you think about that.
It's interesting. And that's sort of another area that I'm working on, sort of how we define success. I think, they just came out with that there are new transplant center metrics that look at waitlist mortality and short-term mortality. I think it's a problem because I think, 1-year success for a kidney transplant is not really a success. When the organ is supposed to last 10, 15, 20 years, I think we have to look longer term. I think there had been talks, and I think it makes sense to sort of almost reimburse better for those that can use the marginal organs well. Because I think one of the biggest problems in transplant is that we don't use the supply we have. I think, our, kidney transplant program, I think, is in a sort of an exemplar of how you use marginal organs well. And I think many of us have talked that, reimbursement should be tied to not just the expected outcome, but if you're able to use something that others can't. Now, again, I think there's a lot of, obviously, like in anything, a lot of, politics to this, because transplant is such a, a big business. But I do think there are talks about it, but I'm not sure how easy that is to happen, because there's so many different payers involved, and how they think about what defines a sort of good outcome is even a matter of debate. If you look at the registries, success, in the University of Florida talks that they have the best liver transplant program based on, their waitlist mortality and 1-year outcome. I think most of us would argue that 1-year post-transplant survival really should not be the benchmark. So I think we still have to have a better frame shift of what defines success before we get into sort of reimbursements based on that.
Thank you. Again, thank you, Dr. Elfassy, Dr. Goldberg, for just beautiful grand rounds today. I want to remind everybody that next week is the 8th annual Eugene Safey Research Day. And at grand round time between 12 and 1, Dr. Elizabeth McNally, who's president of the AAP, will be giving a keynote address. But don't worry, there's something going on all day, and hopefully you can join us on some of the other topics. Check your email for the full schedule, and then poster presentation will be outside from 2 to 4 p.m. with the judging in front of the Lewis Pope Center, and then we'll have the award ceremony in the Triangle with refreshments for all. So please try and put this on your calendar, and look forward to seeing everybody there. Have a wonderful and safe day, everyone. And again, thank you for coming to Grand Rounds.
David, enjoyed Grand Rounds, period.